Yeah.
And has it come?
Yeah, it's coming, but I can see your all the files here.
Now?
No, I can't see your PowerPoint.
Now?
No, sir.
Your screen has come, so you have to
Open the PowerPoint. Open the PowerPoint.
Yeah, this is the PowerPoint, sir. PowerPoint is open.
No,
Yeah, but I can
open,
see your all the files.
open a presentation.
So maybe stop share and then go to the Zoom and then share.
Okay, I'll press stop share. I'll try it again.
Else you can email your presentation.
We'll play it
Okay.
from here.
Yeah, I'll do that, sir. I'll email it to Asmita.
Yeah. Keep it safe so that
I'll email it to Asmita right away.
We go live. We can start, sir.
just check anybody office bearer in the attendee. We can move them to in. Just wait for 2 more minutes. By the time Jason can send his presentation also. So 3:05 sharp we start.
Okay.
I'll just see if Ramesa also joins by that time. Otherwise, Ferry is there very much. Our past president also will be here, Terestita. Perfect.
Asmita, I've sent my presentation. I hope you received it.
Okay.
Happy Teachers' Day to everybody.
Yeah, happy Teachers Day to all of you.
Hello, madam.
Vanessa joined, sir. We messaged
Who?
from Indonesia. Co-chair.
Probably will join in second half. So first half, Raju can take care. She has timing for the prayers.
Prayers. Okay.
So first part, Raju, you would please introduce the Professor Effie.
Hello. Hello. Can you hear me?
Yeah.
Yeah. So good evening, good morning, and good afternoon. Myself, first of all, I'm very thankful to AOSNR for this wonderful webinar. So with this, I am Dr. Raju Takal from Nepal, and I'm as a medical director in one of the specialized rehab center, basically focus on spinal cord injury and brain injury and stroke. And I have experience of more than 15 years in this field. So with this, I like to invite the first speaker.
Just hold on. Just hold on.
Hold on.
Just hold on, Raju. I will. I have not yet started the webinar. Now we'll start.
Okay.
So just to 1 minute. Asmita, can we have a normal webinar? If you can share the presentation. The first, I've got 5 minutes to talk. So there's a welcome and introduction before the if you could take over.
And do keep time because
yeah. So good afternoon, good evening, good morning, ladies and gentlemen. I once again, Dr. Nirmal Surya, President of Asian Oceanian Society of Neurorehabilitation, welcome you all for this fifth webinar of the Asian Oceanian Society of Neurorehab. We have today a big house from the Presidium of AOSNR. We have past President Professor Teresta Joy. We have Dr. Fari Khan, the President-elect from Australia. We have Professor Taslumuddin, the country representative from Bangladesh. And we also have Raju Dakal, who is country representative from Nepal, not to forget Abhishek Srivastava, who has been the key point in making the teaching program for the Asian Oceanian Society of Neurorehab as the chair of education committee. So we by far has now first of Thursday, 3 o'clock Indian Standard Time. This is the fifth of the webinar, which we started in the May. The first was on 2nd May, which was attended by nearly 108 the members. And it was it was a open webinar, which was introductory. Then followed 6th, where we had 212 members from 20 attended, and that was very well attended session. And then we had a third webinar on 4th July, which was in assistive technology for neuro rehab, which was again attended by nearly 201 people from 2 countries. And then 1st August, the fourth one, which was on cognitive rehabilitation, attended by highest number of people, 254 from 17 countries, which is also 2 CME points from the UAE Council. And now today is the 5th September, we have a session on physical therapy in neurological rehabilitation. So I welcome all of you, and the two chairperson who are today's is Raju Dakkal and Rumesha Hassan. Raju, of course, has introduced himself. He is a therapist from Nepal, and he has been working into the field of spinal cord injury. He has been medical director and specialist physician, and spinal cord injury center he's been running. He has been very actively working on various projects, and I have known him for more than 10 years and actively participating in our Shark Country and Asian Society webinar. So welcome, Raju. It was a real pleasure, and we'd really love to have Nepal Society of Neuro Rehab in the future. The second person is Rumesa Hassan. She is a very dynamic lady from Indonesia, and she's the one who is going to do the next Asian Oceanian Society of Neuro Rehab Congress in Yogyakarta. I'm sure she will speak something about that. She's a head of medical rehabilitation installation at Dr. Tajuddin Chalis Hospital. She's founder of RHM Care. She is a KFR specialist doctor, and she's been doing a lot of good work, and she's been very active, and she has got a team which is going to work very hard to get the next meeting going on. So welcome, Dr. Rumesa, for this important meeting as the chairperson. And now I hand over the stage to both of you. Not to forget that first Thursday of every month, we are coming with a new webinar, and the next webinar will be on the 3rd October. End of the session, we will send you. You always please send your comments and your suggestions that how we can make it more and more interesting for our reason, and how we can get the more things to be done for this. And not to forget that the 3rd October webinar will be on the occupational therapy in neurological disorder, and the talks would be focused on ADL and what are the newer changes which are happening in a daily of activity therapy. So we'll come out with the program soon. the speakers in next future. Over to you, Dr. Rumesha and Raju.
Thank you, Dr. Surya, Dr. Nirmal Surya, for the very nice welcome in our session. Ladies and gentlemen, now let's turn our attention to our first presentation. I would like to welcome to Dr. Effie Lin Cho from Singapore. Dr. Cho, the floor is yours.
Thank you, Dr. Rumaisa, and thank you, Dr. Nirmal, for the invitation. I'm very honored to be able to present over here. And today my talk is going to be on motor rehabilitation guidelines and best practices. So I'm just going to go ahead because there's a lot to get through. I'm going to look at the guideline development, and the two guidelines that I'm going to look into is actually the Royal College of Physicians National Clinical Guidelines for Stroke, which was updated recently in 2023, as well as the Australian and New Zealand Living Clinical Guidelines for Stroke Management. In Singapore, we are in the process of developing our own clinical guidelines as well, and our approach is more similar to the Australian, New Zealand Living Clinical Guidelines, in terms of methodology. Well, I'm going to cover today, since we're talking about motor recovery, we're looking at weakness, arm activity, and walking. And I'm going to try and end off with a clinical implementation of these guidelines and an example in robot-assisted rehabilitation. Okay, just going right ahead. You can scan the QR code here for the actual guidelines themselves, and you can pore over them because there's a lot of material in them. I'm just going to briefly talk about the purpose of the guidelines over here. And the guidelines were developed for those providing care, direct care, for nurses, doctors, therapists, as well as care staff. And also we are looking at targeting those receiving care as well, the consumers, patients and their families and their caregivers, and also the funders and anybody else who is interested to provide care for people with stroke. Okay, so in terms of, there's a little bit of difference between the UK and the Australian, New Zealand guidelines in the sense that the UK guidelines do not attempt to grade the recommendations because they feel that grading actually tends to be given based on study design. So methodologically strong evidence for less important interventions seem to get higher priority than those who are in recommendations that are important, but which have weaker evidence. So within these guidelines, they also have quantitative and qualitative evidence where presented where appropriate, and recommendations were made based on consensus also where evidence was not available. So for the Australian and New Zealand guidelines, the methodology was based on the grade methodology. The evidence to decision was based on the balance between desirable and undesirable consequences, and the confidence in the estimates of the effect, as well as the value and the preferences of the clinicians as well as consumers. The cost of the interventions was also considered, giving the strength of the recommendations. Okay, so the strength of the recommendations, they were basically weak or strong, right? So there's a strong for, strong against, or weak for, weak against. And this was based on confidence on desirability outweighing the undesirable effects of the interventions. So sometimes that recommendations for interventions were only given in context of research, where interventions could not be recommended for standard practice at the current time, but there was good rationale to continue further research. Okay, so the implications for the guidelines for the Australian and New Zealand guidelines. For the patients, strong recommendations implied that most individuals would want the intervention, whereas weak recommendations meant that the majority of individuals would want it, but many would not. For clinicians, it meant that most individuals would should do better receiving the recommendation, and adherence could be used as a quality indicator and performance indicator as well. So formal decision aids were not necessary for strong recommendations, whereas for weak recommendations, decision aids might be required. And the guidelines actually did in certain places place some decision aids to help with decision making. For policymakers, the recommendations, a strong recommendation could be adapted as policy in most situations, including for use as performance indicators, whereas for weak recommendations, more debate will be required involving many stakeholders for the indicators to be used. Okay, so the framework used in both guidelines was actually the International Classification of Functioning, Disability and Health, which defines the domain of functioning as body function and structure, the negative corollary of which is impairment, and activities, limitation, as well as participation restriction. And we look at also environmental factors and personal factors that impact on these. So in terms of our consideration today, we are looking at the health condition of stroke. And in terms of impairments, we are looking at weakness, the domain of weakness. And in terms of activity and limitation, we're looking at the domains of arm function and walking. Okay, so we'll dive straight into this. In terms of motor impairment, the Royal College guidelines looked at weakness as well as cardiorespiratory fitness in one recommendation. Or one domain, whereas the Australian ones actually split the two out. Okay, so in terms of recommendation for motor impairment, we are looking at assessing weakness and cardiovascular fitness with standardized approach and with outcome measures covering the range of impairments. The recommendation is also to screen for, prescribe and monitor exercise programs using monitoring tools such as 6-minute walk test, and to individualize programs to goals and preferences of individuals. So B and C are the only ones with that are not consensus-based statements. Okay, so C, recommendation C was to have task-specific, repetitive, intensive exercise to improve strength as a principal approach in preference to all other therapies, including GOBA treatment. So the next recommendation was to offer cardiorespiratory training or mixed training of cardio as well as strength training once medically stable, regardless of the age, regardless of time since stroke, and regardless of severity of impairments. So high intensity should be offered, also remembering regardless of severity of impairment, with an exercise intensity of greater than 70% of peak heart rate, and cardiorespiratory fitness training, such as body weight supported treadmill and or static recumbent cycles should be made available. The dose recommended is at least 30 to 40 minutes per day, per session, 3 to 5 times a week for 10 to 20 weeks. So in terms of moving along, mixed training, which involves medium intensity cardiorespiratory training of 40 to 60% of heart rate reserves and strength training of 50 to 70% of 1 repetition maximum. Such as circuit training should be available at least 3 days per week for 20 weeks. Exercises aimed at increasing heart rate should be used for those with more severe weakness, such as arm cycles or seated exercise groups. The choice of program should be guided by the patient's goals and preferences, and the delivery of the program individualized to the level of impairment as well as goals. So patients with respiratory impairment and risk of pneumonia after stroke should be considered for respiratory muscle training using threshold resistance trainer or flow-oriented resistance trainer at least 20 minutes per day, 3 days a week for 3 weeks. So moving right along, those unable to exercise against gravity should be considered for adjunct to exercises. So this is rather interesting, right? Such as neuromuscular or functional electrical stimulation. Also, maximize exercise adherence, a few measures are recommended, such as to build confidence and self-efficacy using social networking apps, to ensure patient and family and caregivers know the benefits of exercise, as well as to incorporate exercise into documented goal setting, individualizing exercise programs to suit patients' abilities and goals, and also the use of technology such as apps, videos, phone check-ins, etc. And then ongoing coaching to support written exercise instructions, as well as the involvement of family and caregivers with the exercise. So the recommendation is also to not use risk assessment tools that limit training, except where screening has identified intensive exercise as a contraindication. Okay, so in terms of the types of training, treadmill training may be more effective than cycle ergometry, and HIIT training may be more effective than continuous aerobic training for fitness. In terms of intensity, we've already highlighted the high intensity exercises as well as the mixed training. Then high intensity being more effective and HIIT training being more effective than mixed training. And non-ambulatory individuals may use bodyweight supported treadmill training or electromechanical gait trainers or static recumbent cycle ergometry. Although there's insufficient evidence for the specific recommendations. Okay, so there are precautions to be taken. More studies are required, but it is suggested that higher dose, that the complication rates may be higher for those with diabetes and atrial fibrillation. So just looking at the corollary from Australian, New Zealand guidelines, in terms of weakness, the first recommendation is for stroke survivors with reduced strength in their arms or legs to have progressive resistance training, and this should be made to improve strength. So this was the improvement in strength had the effect size or relatively high effect size of 0.98. Functional activity was a moderate effect size of 0.42. Progressive strength training should be noted that it is defined by the ACSM criteria of loads of 8 to 12 repetition maximum for at least 2 sets with increase progressively as the patient improves. So external resistance can also be, external resistance can only be effectively applied for those with anti-gravity strengths. Okay, so in terms of improving weakness, it's also been recommended that repetitive practice using assistive technology as well as CIMT and robotics may be used to improve arm strength. And in the lower limbs, task-specific training, repetitive practice using cycling or electrical stimulation may also help to improve strength, but this was given a weak recommendation. So all these you can see in terms of the effect sizes that these are small to moderate effect sizes in terms of upper limb strength and upper limb activity as well as lower limb strength and activity. So in terms of upper limb and the individual interventions themselves, repetitive, all of them actually result in moderate to small to moderate effect sizes, as you can see here. And in terms of lower limb repetitive practice using cycling, FES, as well as task-specific training, all resulted in small to moderate effect sizes. So the absolute mean increase in the upper limb was also relatively modest in terms of improvement in action research arm tests at 3.1 points only. And in the lower limbs, a mean increase of 0.13 meters per second in terms of walking speed. Okay. So in terms of improving strength, electrical stimulation may be used. In terms of effectiveness in improving strength, the effect size was moderate. It was found that patients who are weak, it was more effective for patients who are weak rather than very weak, and it was more effective for patients who are in the subacute phase of stroke as compared to those who are in the chronic phase of stroke. And there was no consensus in terms of the optimal dose and patient population, as well as parameters in terms of frequency, pulse rates, timing, and duration of intervention. Now, okay, so I'm going to move along from weakness to arm function. So in terms of improving arm function, it is suggested to offer repetitive task practice as the principal rehab approach, similarly, in preference to other therapy approaches, including bull bars. The repetitive task practice, the considerations to take note of are the high number of repetitions, task specificity and functionality, both inside and outside of therapy, being self-directed, bilateral or unilateral depends on the task and the level of impairment, and it should be done regardless of cognitive impairment or neglect, and may be enhanced using trunk restraints and priming. So the recommendation is also to consider CIMT for those with at least 20 degrees of active wrist extension and 10 degrees of active finger extension, as well as to consider FES for wrist and finger extension as an adjunct to conventional therapy for those with wrist and finger weakness and limiting function. Okay, training for the care of a hemiplegic limb is also recommended, with periodic monitoring for change and to offer repetitive task practice if the active movement is detected. Mirror therapy is an adjunct, as is mental practice. Self-directed upper limb practice is also, it should also be added to usual therapy. Interestingly, transcutaneous vagus nerve stimulation was a new addition in the 2023 guidelines to be used for mild to moderate arm weakness, while implanted vagus nerve stimulation should only be done in the context of clinical trials. So robot-assisted movement therapy can be an adjunct as well in the context of, and preferably in the context of clinical trials. So in terms of repetitive task-oriented and task-specific training, these include CIMT mental practice with a lower grade of evidence for VR as well as interactive video games. The dose is unclear, and whether it is unilateral or bilateral, the practice is unclear as well. But likely depends on impairment, and priming may enhance the efficacy. Priming such as brain stimulation, sensory or motor priming is also included. Okay, so in terms of electrical stimulation, electrical stimulation of the wrist and hand movement improves motor function, motor impairment as well as function, and is more effective during task practice rather than passive, and especially to enable the task practice itself. Contralaterally controlled FES can also be used. However, the optimal dosing and stimulation protocol is still unclear. So the vagal nerve stimulation can be used to enhance effect of repetitive task practice. It's found to be safe, but optimal dose parameters and integration into repetitive task practice and candidate selection is also unclear. Okay, so with regards to CIMT, the components of CIMT include constraint of the non-thoracic arm, repetitive task practice, as well as a transfer package to support the implementation into everyday life. And it's found that transfer package is actually the most important component of the CIMT. So the CIMT has been modified in multiple ways, with reduction of constraints, durations, and training hours spread over a longer period of time. And however, the optimal way to modify the CIMT is also unclear at this point in time. So this is appropriate for mild to moderate patients in the subacute as well as the acute stages. In terms of robotics, dose and adoption in routine care is unclear. Whether it needs to be combined with conventional or FES is also unclear, but it appears to be safe and might supplement a face-to-face therapy, and it might decrease the cost as well. So seeking participation in research in these areas would be important. In terms of intensive upper limb programs, the evidence is insufficient. In terms of mental practice, it may be more effective in the first 3 months in severe arm weakness, and for neurotherapy, it is effective as an adjunct, but may be more effective for pain and neglect with less evidence for motor recovery. Okay, so in terms of the New Zealand, Australian New Zealand guidelines, in terms of arm activity, intensive CIMT of a minimum of 2 hours of active therapy per day for 2 weeks with a restraint of at least 6 hours a day can be used to improve arm and hand use. And this was taken with a strong recommendation. So you can see from the effect sizes of that CIMT actually improves arm function better than no therapy with a large effect size. With a significant, a large effect size also for perceived arm motor function in terms of quality and amount of use. There was also improvement in quality of life with a lesser effect for dexterity as well as disability. So in terms of repetitive task-specific training, there was a weak recommendation for this with a small to moderate effect size in terms of improving arm motor function as well as hand function. The optimal way of delivering the method for delivery and intensity is unclear, but trunk restraint seems to be helpful within the period of early stroke recovery. There is this, yeah, okay. So in terms of mechanically assisted arm training, otherwise mostly from robots, this may be recommended also with a weak recommendation. In terms of acceptability, it makes no difference in terms of conventional versus robotic training, with 1 fewer dropout per 1,000 patients. In terms of improving activities of daily living and arm impairment, it has a small to moderate effect size. So the Cochrane reviews included studies using a range of different robotic devices. It's not possible to recommend any individual robotic device at this stage. So virtual reality and interactive games may be used to improve upper limb function, and this was with a weak recommendation with a small to moderate effect size in terms of improving activities of daily living. There was no difference in outcomes between trials that use commercially available equipment as opposed to those who are customized for neurological disorders. Some may not tolerate the virtual reality, as particularly patients with cognitive or visual deficits. And the benefits of VR appears to be related to the dosage of the active therapy that is delivered. Okay, so electrical stimulation in conjunction with motor training may be used to improve upper limb function as well, and this is with a weak recommendation. The moderate to large effect size in terms of improving upper limb activity. When grouped in 3 types of electrical stimulation, being sensory, cyclical stimulation, or EMG triggered electrical stimulation, no difference was found between the groups. So, and that's the effect size over there. Electrical stimulation should be provided in conjunction with motor training and to ensure also enough dosage in terms of amount of practice. And it's unclear whether electrical stimulation is more effective in the more or the less impaired patients. Okay, so in terms of mental practice in conjunction with active motor training, this was given a weak recommendation. So it improves activity to a moderate degree. There are different strategies, but all the strategies involve a visualization of specific movements. Most of them included participants with some voluntary movement, so it's not sure whether this is effective for patients with very severe or very mild weakness. So most of the mental practice were done in conjunction with motor training as well, and action observation was also included in this recommendation. So the optimal dosing is also unclear, ranging from 10 to 60 minutes, performed daily to weekly for 3 to 12 weeks. Patients with communication and cognitive disabilities also or impairments may have problems with this, including those with attention and working deficits in working memory. So time is needed to teach, and it can be time consuming, and it requires focused attention, a quiet location, and assistance from others to maintain the discipline. Okay, so in terms of mirror therapy, this was also given a weak recommendation. The moderate effect size in terms of improving arm activity as well as ADLs. There's no difference between a subacute or chronic patients, and the intensity of training was recommended to be between 15 and 60 minutes per session, 3 to 7 times a week, 2 to 8 weeks. In terms of practice, it's advised to use larger mirrors. Unilateral practice is better than bilateral execution, and manipulation of objects actually doesn't make a difference in terms of outcomes. Some may find it difficult to focus attention on the mirror during their practice. Okay, so there was a strong negative recommendation against using hand and wrist orthosis for routine practice, as they have no effect on function, pain, or range of movement. And we see here that in terms of outcomes in terms of arm function, although there was a slight moderate effect size, it was of low quality. The evidence was of low quality, and there was no improvement in wrist range of movement. So splinting is not recommended routinely for patients with no active wrist or finger extension. Instead, we should use electrical stimulation as well as motor retraining. And those that we think should be splinted, there is a role for splinting in terms of preventing and correcting contractures. But therapists must use the analytical and critical skills when they practice splinting and evaluate it using outcome measures along the way. Okay, so brain stimulation, whether transcranial direct current stimulation or repetitive transcranial magnetic stimulation, should only be applied within the context of research framework. And this was a weak recommendation against the use of it in routine practice. Okay, so in terms of, there was relatively small effect sizes for both TDCS as well as RTMS in terms of improving arm activity. Although the evidence for the RTMS was, the Cochrane review was updated only in 2013. So more recent evidence has not been included. So there's no significant benefit in terms of arm function. However, there may be benefits in terms of impairments in ADLs, but the equipment is not readily available, and hence it was given this recommendation. So also optimal dosage, location for stimulation, and the timings of conjunctive motor trainings are not known at this point in time. So there's a whole myriad of interventions that I have mentioned. So to guide clinical selection of the clinical interventions, we have a few tools. So the PrEP2 algorithm, and some of you may be familiar with this, to determine or to prognosticate whether patients are likely to have to make good or poor outcomes. May be used for the upper limb recovery, as well as the twist algorithm for lower limb recovery, functional recovery. And to make everybody's life easier as well, here is an evidence therapy selection app called Biotherapy that you can download for therapists who are less familiar, or younger therapists, to navigate the myriad of therapies available. Okay, so I'm going to move on to walking now. So people with limited, so these are the UK guidelines I start off with. People with limited walking ability should be offered mobility aids or prescribed suitable mobility aids. This is a consensus statement. Their participation in exercise should be offered to improve aerobic fitness as well as muscle strength. Also, repetitive task practice should be the principal mode of rehabilitation in preference to all other approaches, including bowel bath. Electromechanically assisted gait training can be offered, including bodyweight supports. So those who are able to walk with assistance and who wish to improve their mobility at any stage, interestingly, should be offered access to equipment to enable intensive walking training, such as treadmills or electromechanical gait trainers. So training needs to be at 60 to 85 heart rate reserve for at least 40 minutes, 3 times a week for 10 weeks. So those with limited ankle foot stability or foot drop should be offered AFOs or FES to improve walking and balance, including orthotics referrals. So any orthotics or ES should be individually fitted for long-term use, and training in terms of safe application, as well as risk for pressures, sensory loss, and repair services should be made available for the patients. So, and also specialist assessment should be offered for those who want to have long-term FES use. So in terms of assessing for real-world walking, this is recommended for community mobility, and this should include dual tasking, the impact of dual tasking, neglect, vision, as well as busy environments. Another new recommendation within the 2023 guidelines was the community access to treadmills and other fitness equipment. And also, again, it is indicated that we should not use risk assessment protocols that limit training for fear of cardiovascular or other adverse events, given the good safety record of repetitive gait training, however it is delivered. Okay, so in terms of repetitive practice of walking, in the Australian New Zealand guidelines, this is given with strong recommendations and may be used in terms of circuit class therapy or treadmill training with or without body weight support. And this is the evidence for this, for it. 115 circuit class training can result in 159 more independent walking, and more patients with independent walking per 1,000. And it also includes walking speed to a lesser degree with a small effect size, and walking on endurance is significantly clinically importantly improved. Okay. In terms of treadmill training, the evidence for this is weak for walking, for improving walking speed, but a little bit better for improving walking endurance. So in terms of repetitive practice, this was there was moderate effect size in terms of walking speed, improving walking speed, walking distance, as well as functional ambulation. Okay, so in terms of adjuncts, these are a few adjuncts that were given weak recommendations: virtual reality training, electrical, mechanical assisted gait training, biofeedback, as well as cueing of cadence, as well as electrical stimulation. So in terms of the robotic gait training, it improves independent walking in the order of 172 more likely to achieve independent walking per 1,000. And in terms of walking speed, there was a smaller effect size, and it was not significant. And there was also not a significant increase in number of deaths. So electrical stimulation also improves. There's really small evidence for improving walking speed. And in terms of virtual reality, it improves walking speed, walking ability, as well as functional ambulation with this order of effect sizes. Cadence cueing also improves walking speed to a small degree, and joint position feedback improves lower limb activity to a moderate degree. In terms of individually fitted lower limb orthosis, it was given also a weak recommendation. It improves walking ability and walking speed, but the evidence now supports customization to suit the patients and to address walking deficits identified during gait analysis. Okay, so that's all for the guidelines. Okay, so I am going to look at beyond the evidence, looking at implementation of these guidelines. The implementation research seeks to accelerate adoption and integration of evidence practices, interventions, and policies into routine healthcare and public health practices. So we have to move from along this graph from efficacy studies to look at effectiveness studies and eventually implementation studies. Right? Okay, so when we look at the implementation process, all these stakeholders should be involved from the very top, the funders, all the way down to the consumers, and in between the users, the clinicians, as well as the healthcare organizations and players as well. Okay, so these domains may be looked at in terms of implementation research, acceptability of the intervention, including perception amongst the stakeholders, adoption and what impacts on adoption, the appropriateness of the therapy, as well as the feasibility and the extent to which the intervention can be carried out in all sorts of different settings, the fidelity to which it is delivered as compared to what is delivered during research, and importantly also the cost. So this can be done through qualitative, quantitative, or mixed methods research. And I just want to look at robotic gait training as one example that we have attempted to do some implementation research in. We know from the Cochrane review that it improves the rates of independent walking with less effect on walking speed as well as walking endurance in stroke patients. And there's a comparison of any factors as well as exoskeletons in these regards. In terms of upper limb robotic gait training, upper limb arm training, it improves ADL's function and arm function and arm muscle strength to certain degrees. But the VATULS trial actually undertaken, a large pragmatic multi-center trial actually demonstrated that there was no benefit in terms of robotic upper limb training as compared to enhanced upper limb training with high intensity. So also in terms of economic evaluation, robotic upper limb training was not found to be cost effective as compared to standard care. Okay, so just looking at our continuum of rehabilitation in Singapore, stroke patients who have significant deficits are admitted to acute inpatient rehabilitation or community hospitals for inpatient rehabilitation, and subsequently they are discharged to day rehabilitation centers for continuation of rehab. But we do find that we have a problem with compliance to day rehabilitation attendance with a compliance rate of about 20%, and this is relatively old data, 20% of compliance at 3 months. The reasons that the patients actually give initially was the inconvenience of not having caregivers to go with them. And eventually, they after 3 months, they do say that they do not find the treatment effective. So we actually undertook a study to look at implementing exoskeletons, robotic exoskeletons in rehab centers, hoping to improve the compliance as well as to get some feedback from the patients and also to improve the effectiveness of weight training, weight rehabilitation. So this was the aims that we stated, and we tried to employ exoskeletons all across Singapore. Right, so the map shows the small island of Singapore with all the centers that we tried to implement the robotic exoskeleton training in. It was inpatient as well as outpatient, from hospital to day rehabilitation centers and nursing homes. So the intervention group got 12 sessions of exo and overground training, and the control group got 12 sessions of usual therapy. So these were the outcome measures, and I will go quickly through them because it was a pragmatic trial. So in terms of recruitment, we had, and I'm showing only the baseline data for the stroke patients that was recruited into this study, not counting the spinal cord and other diseases. So we see that there was, in terms of baseline FAC, there was actually more severity in terms of functional ambulatory category in the exo group as compared to the control group, and also whether they are inpatients or whether they are outpatients. Okay, so and in terms of recruitment, across so these two centers were inpatient, had inpatient as well as outpatient rehabilitation, as well as JCH also had inpatient as well as outpatient, whereas the other centers had outpatient only. And we found that the facilities with inpatient as well as outpatient exoskeletons or rehabilitation patients actually recruited more patients. So these were the results for the stroke patients. Of 149 patients, 105 of whom did exoskeleton training, and 34 of them were controls. In inpatient care with an onset of stroke less than 9 months. Both the exo and the control groups improved significantly in all motor outcomes with no significant difference between groups. And participants with baseline FAC1 had significantly greater improvement in motor subscore of FIM as compared to controls. The improvement was above minimally clinically important difference in the exo group only. So in terms of distance walks, this was significantly greater for those with FAC 0 and 1. It was not, the difference was not observed with those FAC 2 and 3. Okay, in terms of feedback, the exoskeleton training actually got relatively good feedback. And other lessons we learned was that, as I mentioned, the center distribution, 82% of them were from inpatient and outpatient rehab centers. And we found that there was a critical size required for the facilities to be able to implement the exoskeletons in the day rehabilitation setting. And they needed to have complex rehab capabilities and referral source with close contact with the referral sources. So this is a framework that was suggested in Journal of Neuroengineering Rehab. In terms of choosing the robotics, but particularly for robotics gait training. Okay, so in terms of next steps, we needed to look into developing partnerships with between hospitals and community partners, and we also thought that we needed community practice for a community of practice for advanced rehab technologies. Also, we are submitting for these results for practice guidelines, and we also recognize the need to develop capabilities for implementation research. Okay, so that's all I have. Be happy for any questions or questions after this.
Thank you.
Raju, you can.
Yeah. Thank you, Dr. Chiu, for underlining presentation about current trends in motor rehabilitation guidelines. And next, we have Dr. Jason David Arumbu from Qatar, who will discuss about tailoring exercise programs to different neurological conditions. Dr. Jason, time is yours.
Thank you so much, Doctor. A big thank you to Dr. Nirmal Surya, Dr. Abhishek, and the whole team of AOSNR for having me over here. Thank you so much, Dr. Maisa, for the wonderful opener. Asmita, if you could help me with the presentation. I must thank Dr. Effie also for that wonderful presentation. The amount of information that you shared in that presentation was huge, but you managed to concise it and make it very clear. I actually like the last part of the presentation, which said that the guidelines are one part, and implementation of the guidelines is a totally different thing. And my presentation is basically taking the second part, the implementation part, and seeing how it goes. So my topic is tailoring of exercise program in neurological conditions, and I have no conflict of interest. The learning objectives that we will try and achieve at the end of this presentation is gain an understanding of tailored exercise program, identify the factors to consider when designing a tailored exercise program, understanding the advantages of a tailored exercise program, and implementing or evidences of use of tailored exercise program in some common neurological conditions. Yeah. So we'll basically divide the whole three words, tailored exercise program, and then we'll take it up together. Exercise is defined as a subcategory of physical activity and includes those activities that are planned, structured, repetitive, purposive in nature, and intended to improve one or more components of physical fitness. So this is the exercise. What is tailoring? So tailoring can be defined as gathering or assessing information from persons to develop and deliver individualized intervention components. The word tailoring basically can be substituted by words like customization, individualization, and personalization. So I just have put another definition of personalization. Personalization can be defined as a process which changes the functionality, interface, content, or distinctiveness of system to increase its personal relevance. So taking this together, what is a tailored exercise program? A tailored exercise program is nothing but a set of exercises created after assessing an individual through multiple lenses in order to arrive at an individual program which would maximize his or her benefits and adherence to that program. So the next question that comes to your mind or our mind is, why should we have tailored exercise program? And all of us are very much aware that every patient and every condition in neurology is so different that unless we see them differently, we will not be able to provide a precise care pattern for them. And just taking a small example very quickly out here, we have a patient who is maybe 40 years old, active, and having right hemiparesis, who was a runner. And we have another 60-year-old patient who had a sedentary lifestyle and still has right hemiparesis. The body weighted supported treadmill training for gait is useful, and I can either apply it on the treadmill or the overground. But if I use the treadmill for the 60-year-old sedentary patient, and if I use the overground body weight supported for the 40-year-old patient who is very active, I think the outcomes will differ. But if I would have gone and assessed his previous past and known that he likes running, he's an active guy, he's probably run on a treadmill, he would probably enjoy and be more involved in exercise. And we must all totally get this in, that exercise cannot be injected into the body. The patient has to be involved, has to be motivated and driven to do the exercise, and only then can we achieve change. So tailored exercise program basically deals with the fact that every patient is unique, every condition is different, and we need to create a different and a unique program for each patient. So how can we tailor this exercise program, and what are the factors that we should consider by tailoring of an exercise program? Uh, so we have five factors basically. We have motor symptoms, non-motor symptoms, comorbidities. Now, to be very true and plain, these three factors are the ones that are the most easiest and the most commonest ones that we will assess for: motor symptoms, non-motor symptoms, and comorbidities. The next two factors, which are personal factor and contextual or environmental factors, are the factors which we may commonly miss out on. But these two factors actually play a very important and a crucial role in deciding what sort of exercise or what sort of treatment program that you should create for the patient. We will take up each factor separately, beginning with the motor symptoms. So motor symptoms, basically, you will all, I mean, we all will assess at baseline, and these will basically include spasticity, weakness, pain, which can hamper our treatment program, balance impairments, which you should focus on, gait impairments, and all these are the common things that we will assess for. The non-motor symptoms are again things which we will assess, especially the cognitive dysfunction. Uh, Whether he's oriented, whether he's able to follow simple commands, and things like that. But the next two factors in the non-motor symptoms, that is anxiety and mood, are some things which we may miss. And I want to give a very quick example over here for anxiety and mood, just because we are actually dealing with a patient right now whose non-motor symptoms was missed by us. The patient had a cervical discectomy, came with a classical like a picture of a hemiplegia. We quickly started treating him as having zero power in the upper limb, lower limb, got him to stand. Uh, till standing frame within 10 seconds, 20 seconds, dizzy. So we said, okay, let's go slow. We shifted him to the treadmill, to the tilt table. Slowly started going up. At 60, he would say dizziness. What we missed was, because as we have a case manager over here, and as we discussed this case with the case manager and the doctor, the physician, something that we missed was this person had a personal trauma wherein he had lost two of his wives and one of his child in the last 3 months, 3 months ago. This trauma probably exaggerated the symptoms from the cervical discectomy. That means the symptoms probably were not matching what surgery he had undergone. So the basic thing was, if we were to just continue to the same, we would have been stuck at 60 degrees, not knowing what to do and how to progress. But since we came to know about this personal trauma, his mood and anxiety part, we kind of cut down on our aggression. We started going slow with him, talking to him, and then slowly progressing our exercises. And we were actually able to progress in the next week or 10 days to walking with the Canadian frame. So understanding the non-cognitive symptoms is also very, very important. The third one, which is again, which easily assessed and commonly assessed, is comorbidities, and which can include orthopedic problems like a recent fracture or limb length discrepancies, diabetes, hypertension, cardiac issues, pulmonary issues, all this which will affect the intensity of the exercise program that you give. So these are three commonest factors that will be assessed by us. And let's move to the other two factors, which is personal and environmental. Environmental factors, this is something which we may miss, not that we will or always miss. Physical constraints, to know where this patient comes from, because as therapists, we will be inclined to treat this patient for leveled surface gait rehabilitation. We probably are not imagining his surroundings at any point in time. We will treat him, okay, level surface, supervised, and we discharge him. And the moment he goes home and we receive a call saying that, sir, that we are not able to walk at all. And so then we check what happened. And then he'll say, we actually have downslope and upslopes in the whole area. And the moment I go slow, I go downslope, I lose my balance, and upslope, I can hardly walk up. So understanding the physical constraints of the patient where he lives may also play a role in deciding or uh, contouring your treatment. Like, you would probably like to get him to do an upslope and a downslope so that he's practiced that before he reaches the home. Second thing is within house constraints. Sometimes you have a patient who has to probably climb 14 stairs to reach his home and there is no elevator. But as part of your practice, you probably train him for 3. And as the patient goes back, he has to actually do 14 stairs to reach his home. And after 3, he may wonder, will I be able to reach this 14th stair? So if possible, if we know about his home surrounding or his home situation, we will probably incorporate these particular aspects as well, because those were important for him. Stair climbing was very important because he had no other go. So our goal is to always not only look at the physical aspect, but also understand the environmental and the personal. Let's go to the personal, the last factor. Personal factor, this is something which Dr. Effie also said, personal aim and goal and preference. These matter a lot because underdosing and overdosing of therapy is very common if our goals don't match the patient's goal. For example, we have a patient whose goal is to just be able to walk from the bedroom to the living room and bedroom to the washroom and go once a week down to the ground, to the ground floor or to the garden. That's his goal. But as a therapist, I want him to be a community ambulator, walk at 0.8 meter per second, be able to do, close to 300 meters in 6 minutes. And my goals are a way aggressive. So I will probably be overdosing this patient, and this patient will start feeling negative about coming for exercise. And I could also underdose. There is a patient whose goal is, whose work probably, or whose aim is to go back to work. And he has to do walking around off, the floor. He has to walk 150 meters, maybe 5 or 10 times a day uh, to deliver something or whatever. And I am probably just trying to make sure that he's able to ambulate under supervision safely. I will be underdosing this patient. So the aim of the patient is very crucial while you decide or tailor the goal. And second thing is preference. Yeah, you probably have a patient who was a swimmer or who came from a place where there was a lot of beaches and things, and he loved water. And my therapy was focused on land based, and I probably had the liberty or the this thing to push him into a aquatic session. But because of my predominant move towards treating him on land based, I never actually thought that maybe if he likes water, his motivation, his involvement in exercise would probably be higher if he would have gone for aqua. And last thing is presence and absence of caregiver. This is basically like how Dr. Effie said, continuum of rehabilitation. Because as the patient moves out from rehab, inpatient rehab care, we will always suggest home care or home exercise programs or outpatient rehabilitation without knowing if the patient is actually having a caregiver to help him do the home exercise program or help him reach outpatient department. So we should also know whether this patient has some sort of social support when he goes back while prescribing home exercise program or telling him to go to an outpatient department. So there are basically 5 factors which we really need to be careful about. Next is, why go through all this effort? The why take all this effort of understanding personal, environmental, non-cognitive, non-motor, motor. The idea is that tailored exercise program will, with all these factors taken into consideration, will lead to precise rehabilitation. And the word precise, because you will assess him not only for his motor but his non-motor symptoms, and also work towards a goal which he has in mind, or you and the patient together have decided on. Because if your baseline assessment is wrong, your goals are different, your therapy is not going to be precise and not affect or not look at the impairments that is leading to his inabilities. So precision is one thing which will be achieved using tailored exercise program. The second thing, like I've already said, is that exercise is not a pill or not an injection, and the involvement and the motivation of the patient is paramount. Nothing can now replace that. If the patient's involvement and motivation to do that activity, to do that exercise, to do that number of repetition is not there, your program is not going to achieve the goal in the specified time. The third thing is time. Time, there are two things that we need to be really worried about. One is the in-session time, because I don't know how things are in all the places, but usually that what I've seen is that your per session time is restricted to 45 minutes to 60 minutes. And if you are not able to provide exactly therapy that can create the change during that time, then you have lost the efficacy of that session or the time that the patient has spent with you. And the second thing is the duration that the patient stays in inpatient rehab. For example, in our center out here, our patients are only given 6 weeks and the upper limit being 8 weeks. So the total duration that the patient spends is either 6 or 8. And your goal is to try and achieve maximal benefit for the patient during this time. So if you don't tailor your exercise program to target every impairment or specific impairments that he wants to be target to achieve, then your time is wasted. And last thing is adherence. Adherence, because all these patients will move from inpatient care to outpatient or to home exercise program care. And if they have to adhere to it, they have to be really involved and be able to like the program that they have been selected for or been given. So four things which will be advantages by using a tailored exercise program. Very quickly, your tailored exercise program, this everybody is aware of, is going to be prescribed in the FIT format, that is frequency, intensity, time, and time. I'll quickly put an example on the next slide of how this would probably look.
तीसरा आता है वाइड एंगल और
Next slide.
4 kg, लेकिन 4 kg से प्राइस बहुत डिफरेंस है, मेरे ख्याल से वाइड एंगल वो है.
Yeah, this is how a exercise program in the FIT format will look like. We'll quickly take this aerobic part over here on the left, and we will see how it is prescribed. So in FIT, what we look for is frequency. So frequency is very clearly written, 3 to 5 days a week. The second thing is intensity, and intensity you can see over here, rate of perceived exertion to be 11 to 14. The third thing is duration or time, and 20 to 60 minutes per session. So you have completed FIT, T. And the fourth one is T, which is type, and that is aerobic. So this is how you probably prescribe an exercise program. You usually will have 4 things: aerobic, strengthening, stretching, and balance components. And prescription will be done in this format. So where can you apply this? You can apply this basically across inpatient care, outpatient care, and for home exercise programs. So you can apply this a tailored exercise program across all the 3 continuum of rehab. So inpatient can be said to be acute care, outpatient can be said to be as subacute care, and your home exercise program can be said to be equivalent to chronic stage of care. So you can apply this across the continuum of rehabilitation. Asmita, I'm so sorry. Yeah, so like I said, application of the exercise program, inpatient, outpatient, and home exercise program. So now moving to our tailored exercise program in common neurological conditions. I have kind of divided this into 2 halves. Basically, the first 3, traumatic brain injury, Parkinson's disease, and multiple sclerosis, I have taken up as an article from the literature, and seeing whether this tailored exercise program is beneficial in these conditions. And the last 2, stroke and spinal cord injury, we will see a case scenario and see how a tailored exercise program is implemented. So beginning with traumatic brain injury, this article was taken from JAMA Open Network 2023, the title being Effect of an Individually Tailored and Home-Based Intervention in Chronic Phase of Traumatic Brain Injury. So the objective was obviously to evaluate the effect of home-based, individualized, goal-oriented rehabilitation intervention in chronic phase of TBI. So what they meant by the inclusion of the patients, the chronic phase were patients who were more than 2 years post-TBI. these patients had to have the ability to consent for the study, and they should also have had the ability to create 3 targeted goals that they want to achieve at the end of the program. These were the 3 inclusion criteria. Now, what did the intervention group? So basically 60 patients were divided into the intervention group and the control group. Now, the intervention group basically had 8 sessions of guided either face-to-face or video or tele rehabilitation for 4 months. So basically they were divided into 2 sessions per month into 4. And the control group basically got a handout of exercises which they had to do generally. Outcome measures were primary quality of life and social participation, and secondary were targeted outcomes, like what those 3 goals that they created, what were the outcomes at the end of that, and psychological and anxiety scales. At the end of 4 months, what they found was that only the intervention group, the group which received 8 personalized sessions, showed improvement in the secondary measures. And at the end of 12 months, both groups actually showed improvement in the primary and secondary measures. However, the intervention group significantly showed a greater improvement as compared to the control group. So they concluded that an individually tailored, goal-oriented home exercise program can create a difference in the chronic stage of traumatic brain injury. The next one is seeing how tailored exercise program had an effect in Parkinson's disease. This was an article which I took from Journal of Neurology, Neurosurgery and Psychiatry, 2019, title being Multi-Center Randomized Controlled Trial of PD SAFE, a physiotherapist delivered fall prevention program for people with Parkinson's. So what happened here is that this is again a home-based exercise program. So they created a program. So objective being to estimate the effect of physiotherapist delivered fall prevention program for people with Parkinson's. The inclusion criteria was people with Parkinson's who were mobile using an assistive or without an assistive device, and who also had a recorded fall in the last 12 months. So these were the inclusion criteria for the patient. This was quite a big study, I think 120 patients in each group. The intervention group, which is the PD SAFE group, actually had an individually tailored progressive home-based fall avoidance strategy training with balance and strengthening exercise. So actually they had 3 components over here. They had fall prevention strategies, they had balance, and they had strength. 3 things that were taught to the intervention group. And the control group basically got a DVD which says that how can you prevent falls and what are the general exercises to do in Parkinson's. The outcome measures, the primary outcome was number of falls that these patients encountered at the end of the 6 months. This was a 6-month study or a home program exercise study that they did. And the secondary outcome was balance scales and quality of life and scales which are related to non-physical outcomes. At the end of 6 months, they actually found that the number of falls in people who were in the interventional group were more than the people in the non-intervention group. However, all these secondary outcomes which were related to physical and non-physical measures, mini best being for balance, chair stand test being for balance and strength, your fall efficacy scale, freezing, all these secondary parameters had improved in the intervention group. So they concluded that maybe the severity of the disease could have led to the primary outcome not being improved in the intervention group. And they said that further confirmatory trials of fall prevention strategies on targeted groups of people with Parkinson's are recommended. The third one is to assess the efficacy of tailored exercise program in multiple sclerosis. This is a very common condition. So this is taken from BMC Neurology 2015. A personalized intense physical rehabilitation program improves walking in people with multiple sclerosis presenting with different levels of disability, a retrospective cohort. This study basically was to test the efficacy of an integrated tailored physical rehabilitation program on walking in people with MS categorized according to the level of neurological disability. This was retrospective study. So what they did was they already had a program running for MS, which was a 3-week program, which included both physical therapy, occupational therapy, and speech. And the therapies in the intervention group, or basically the people who underwent the 3-week program. One was goal diet physiotherapy, second was moderately intense aerobic exercise, and third was aquatic therapy. Total duration 3 weeks, total number of sessions 30 sessions. At the end of this 3 weeks, they assessed a few outcome measures, which is the 10-meter walk test, looking for speed, the 2-minute walk test, looking for endurance, and the timed up and go, which is more of a balance and a test for balance and strength. And they found that the 2-minute walk test, 10-meter walk test, and the timed up and go all basically improved after this 3 weeks interventional program. But the major improvement, or the statistically significant improvement, was only in the 2-minute walk test. The 10-meter walk test and timed up and go did not have statistically significant improvement. And they concluded that there is definitely a positive effect of a tailored integrated PMR program on ambulation and MS population. But this is a very huge limitation out there, because they just did a retrospective, and there's no control group to see whether there's another program which actually had similar effects or no. And the program, they did not see whether there was any carryover effect, probably at 6 months' time or at 1 year's time, whether these patients actually had any carryover of the benefit that they encountered after the program. So quite a bit of limitations out there in that study. Moving away from the research, we will go to a practical setting of how to see a tailored exercise program in stroke. So this patient came to us maybe around 4 months back. 57-year-old male, brought with right-sided upper limb and lower limb weakness associated with facial deviation, slurred speech, no loss of consciousness, no headache, no chest pain, no vision changes, no trauma, brain injury showed, left MCA stroke. Received for rehab after 7 days of acute care. What's his occupation? His occupation is a senior police officer. Why the occupation? Because out here, being a senior police officer is a position of command. So the way you deal with this person has to be different from the way you deal with a normal employer or normal worker who's come for rehab. And he lives, he's a divorcee. He lives alone in a villa with his son and has a driver for driving him around. These environmental factors are also now considered. The goal, as per what he wanted, was to become like before. This was his goal, very straight goal, to become like before. But goals have to be tapered. The therapist has to give some realistic goal and taper the expectation of the patient so that the goals are kind of achievable. So tapered down to, after discussion, able to walk without help under supervision or independently for 100 to 150 meters. He said that I have a mosque 100 to 150 meters away from my house. I should be able to go over there independently. He said that he had 5 steps to climb to enter his house, and he should be able to do that. And since he already has a driver, his only next concern was entry and exit into the car without assistance. We'll look at his examination. His high mental function was good, conscious, oriented, alert. Sensory system, well, within normal limits. There wasn't much impairments in the sensory system. Yeah, his tone was again within normal. This is, remember, the 7th day after stroke. The power on the right upper limb, grossly 1/5 on the shoulder, and the rest was 0. Right lower limb, again, hip was 1/5 and the rest was 0. The left side was 5/5. His sitting balance was poor, both in the static and the dynamic phase. The standing balance obviously was, he was not able to perform because he was totally falling off. And his transfers were total assist. The scales were FAC, functional ability category scale 0/5, work balance scale 2/56, trunk control test 12/100, trunk impairment scale 0/23, and we had FIM and MMSE taken. Were quite affected for FIM, and MMSE was normal because he had no cognitive issues. So we'll quickly go. Like I said, 6 weeks is what we usually get for rehab in our center, and 8 weeks is the maximum. So we started with the initial week of rehabilitation by focusing on bed mobility and leg exercises, trying to give him as much as leg exercises as possible on the weaker side, and trying to get him to roll to both the sides. because once he starts rolling to both the sides, he'll be able to offload pressure. His both the sides of the body will feel things. He'll be able to come to sitting from that position. The next thing that we focused was sitting balance with static and multi-directional reach outs with the use of a biofeedback mirror. So we just got him to sit because static sitting itself was poor. So we basically had to get him to sit without losing his balance in the beginning, and then try to achieve something on top of that foundation. We worked on standing tolerance because he had no standing. So we got him to do on the standing frame, and then we increased the time that he stood for from 5 minutes to all the way up to 20 minutes. And we worked on his transfer. So to begin with, we worked on the transfer using a transfer board because that was the only way he could transfer. And progression to the next week, we continued with the bed mobility. That did not change at all. But what we did is that from the standing frame, we did not just push him to the standing frame, strap him up and get him to stand for 20 minutes. We actually got him to do a little bit of sit to stand in the standing frame. So we kind of changed the way we use the standing frame to get sit to stand as well. Of course, we needed to help him. He had to hold on to the standing frame to pull himself up. All these things were there. And the sitting balance workout continued. Yeah, Asmita, you can go on. And what we changed is the setting of the standing. So we were able to give him tolerance there. We were able to do sit to stand there. We slowly pushed him to the parallel bar and got him to stand with 2% assist, so that he now is able to be more confident of his standing. And transfer training continued with the board. So after 2 weeks, we actually have a reassessment every 2 weeks. So we again reassessed him very quickly. Now what happened is that the right upper limb, there was increase in tone. Mild, but definitely there was tone that's what's coming in. Upper limb power had kind of improved a little bit, grossly 2/5 shoulder, 1/5 at the elbow. And his lower limb power also had improved a little bit, 2/5 at the hip and 0/5 at the knee. His sitting balance, obviously the left was always normal. Sitting balance was static, now fair, which was poor. And I know he was still poor. Standing balance was again poor, but he's at least able to stand now. And transfer was maximal assist, squat pivot. Okay, so usually we start with the transfer board, then push to squat pivot, then try to go for stand pivot. So his FAC scores unchanged. BBS score from 2 became 4. Trunk control because of his mobility training changed to 24. His, because his static sitting got better, was 2/23. And his swim increased to 74. Now we go for week 3 and week 4 of rehab. Now we slowly change because right now we were not using any equipment. We were basically just trying to get him accustomed to the amount of effort. Like I said, police officer, driver, his lifestyle is pretty much sedentary. Now what we did is we got a rehab matrix, which is basically a system which is similar to the Nintendo Wii. You can basically challenge a patient for sitting balance or upper limb activities or activities in standing using a screen. So we used rehab matrix to challenge the sitting balance because already static sitting has been achieved. So we need to push him higher. So we got the rehab matrix in. We wanted him to start initial walking, and robotics was the best way. So we initiated Locomat with him. The first session was probably for 15 minutes, but the problem was at the end of the session, he totally disliked. We told him that no, this is just the first session. Don't worry, we will probably do another session, and you'll get used to this whole thing of strapping up the legs and strapping up the chest, the pelvic area. But unfortunately, the second session, after he did the second session, which was even shorter, 10 minutes, because he said stop, we had to basically discontinue the Locomat with him. So in spite of having an equipment, in spite of knowing that, okay, in the initial phase and a non-ambulatory patient, this robotic probably could help, we couldn't use it. Then we worked on his transfer using the squat pivot. So now we've removed the transfer board from him and we've started using the squat pivot transfers. And sit to stand training from the edge of the bed. So again, we moved out from the parallel bar, giving him more confidence of his abilities and moved to the edge of the bed, high sitting. Standing balance with 1% assist. So again, out of the parallel bar, 1% assist standing. And now we introduced the Motomed, which is nothing but a cycle ergometer in assist mode to probably give him a little bit of aerobic activity. Rehab week 4, because the Locomat failed, we said we will now try the bodyweight supported overground walking. So we initiated bodyweight supported overground walking, which fortunately for us, he was kind of okay with. he said, this is much more freer. I feel I am in control and I can do things. That I am in control. That's again part of his personality, that I am in control, because police officers are always in control. Static standing with quad cane and stepping in place. So we've now got him to use an assistive device as a precursor to kind of get him to start walking over ground with the quad cane. So we kind of give him the confidence that this is how it's going to be. We also introduced aquatherapy. We have a pool, we have specialized therapists out here, and we decided to give him an opportunity in the pool. And he kind of liked that as well, which he agreed to for 2 days a week. We reduced the assistance for transfer. We are again now moving from squat pivot to stand pivot. The stand pivot transfer is the one that we have to achieve. This is our goal. So stand pivot transfer, we reduce the assistance and we worked on the transfer. Standing balance, like we said, the last time we were working with the quad cane and static standing, and now we've decided that, okay, standing balance, we can probably do dynamic by giving him reach outs, and we continue with the motomed. So we have finished 4 weeks. So again, 2 weeks over, we have to reassess him. So we'll quickly go to the reassessment. So this is the second reassessment, so the initial assessment first, and this is the second after 4 weeks. The tone in the upper limb increase. So has the power, which has kind of become 2/5 at the shoulder, 1/5 at the elbow, but nothing in the wrist and finger. Right lower limb is again kind of become better. The hip has become 3-. The knee is kind of also picked up 2-, but the ankle is gone. We are forced to use a ankle foot orthosis out there, a dynamic one. The left upper limb and lower limbs are good. The sitting balance now is both good in the static and the dynamic phase. So at the end of 4 weeks, our static and dynamic sitting balance has become good. Standing balance has become fair in static and poor in dynamic. And transfers has become minimal assist, from total assist to minimal assist at the end of 4 weeks. FAC is 1/5. The BBS score was 4. Now it's progressed to 17. PCT was 24, has become 50. TIS has moved from 7 to 10. So all the scores also have moved up, and we have also changed the way we treat him by giving him more techniques of more assistive devices and things like that. Now coming to 5th and 6th week, this actually is usually our last 2 weeks with the patient. So because his standing balance is quite good, we have the vertex balance master over here. We introduced this to him because usually a patient who can manage to stand more than 2 minutes, we usually encourage this patient to now move on to the next level, where he will be moving his limb of stability, getting a direct feedback, moving the base and things like that. So we shifted him from just static standing balance and reach outs to the vertex balance system. His aquatherapy continued. His body weight support overground training, which was happening in week 3 and 4, was discontinued for overground training with the quad cane, which in week 4 we had initiated by getting him to stand with the quad cane and do stepping. So we already had the precursor working out there, and then we progressed to this. So we have removed his body weight support and gone for overground weight training with the quad cane. And like one of his goals was stair climbing, and this was something which we had not touched till now because of his balance issues, because of his weakness. But since all this has kind of improved, we then moved on to stair climbing with the use of side arm, side rail, and maximum assistance. So this was initiated. We usually do 3 steps up and 3 steps down. This is what we usually do. Our goal is though 5. So we started with 3, and as week 6, we usually progress to the next. Cybex cycling was something which we introduced. We changed from the Motomed, which is assistive, to Cybex, which is totally active, and we gave him 10 to 15 minutes of that. We'll go to rehab week 6. Rehab week 6, now from the vertex balance system, which we gave for only a week, because since he was doing good, we said, let's move him to the rehab matrix again, but this time with in standing. So all his exercise in rehab matrix was in standing now. So a lot of dynamic balance being trained there. And we started training him for the treadmill, something which we were doing overground. Now we shifted to treadmill with overground walking as alternate. So one day we do overground walking with the quad cane, and the other day we do treadmill training with the harness, lightly attached to him. And stair climbing continues as expected, and we managed to push him to 5 steps by the end of the 6th. We were lucky to get 2 weeks extra with him because of the progress that he showed. And on reassessment, at the end of 6 weeks, his FAC was 2/5. That is minimal assisted walking. BBS was 26, which is medium risk of fall. TCT was 74, and TIS had pushed up to 13 with FIM at 18.9. Sitting standing balance good, and transfers was supervised now. So he's supervised for transfer and he is minimally assisted for walking. Our goal was to achieve supervised or independence in walking and be able to do 5 steps independently. So we've achieved at least supervision. Now we got 2 more weeks with him. Like I said, let's move to week 7 and 8. Yeah. So in week 7 and 8, aquatherapy continued, treadmill training with harness. And what we did was start increasing the amount of time that he was there on the treadmill. We introduced virtual reality into the picture because now he's about to go out because 7 and 8 is the maximum. So that's like the end point. We're nearing end point. So now what we did is that he's used to treadmill training in week 6 and 7. So what we did is that we added virtual reality treadmill training because this will add another complexity, a layer of complexity in his treatment because now he has to focus on his balance as well while looking at objects. So we added that, and the stair climbing continued. We've achieved a goal of supervised. We want to attempt to make him independent for stair climbing, and cycle for its aerobic capacity was continued. And the last week, that is week 8, his rehab matrix workout and standing continued. We introduced easy street training. This is a particular area in the rehabilitation facility that we have where there is a car available. There are signals. There are road crossings. There's a small supermarket like area where the patient who's about to get discharged gets to train. So basically, like a real life scenario. So we got him to go there, do his car transfers in and out, which is very easily done because of all the improvements in power and balance that he had achieved. And we continued with this virtual treadmill training because this is again real life scenario that is being played out. At discharge, this patient had achieved his goal of being able to be supervised in his ambulation, and he was a moderate risk of fall because his BBS had become 32. We told him, please continue his training as outpatient, and he was motivated to continue because he had achieved his basic goals of being able to walk supervised and being able to enter the car without assistance and being able to do 5 steps. The achievement of his goals led to him being motivated to continue with rehabilitation because many times what happens after inpatient rehab, they are not motivated to go further. Why? Because they probably haven't achieved their goals or they were overdosed with therapy and they were like, oh my god, I'm done with this. So this was his this discharge assessment at 63 days, and we were able to achieve most of the goals that he wanted to. So we tailored his program from being just on the bed to moving onto a robotic system which failed. We pushed him to the overground body weight assisted walking, then treadmill, aquatherapy, Bertec, and lastly, environmental. By looking at his environmental, we did virtual reality and we did easy street. So this was the way we tailored his program according to his goal and his preferences. Preferences matter a lot. We'll quickly go to the spinal cord injury case scenario as well. 40-year-old guy had a fall, diagnosed with central cord syndrome, multiple fractures of ribs on the right side, fractures of the spine, T5, T67, underwent a fixation for the same, came to us at 40 days after the injury. Stabilization of the fractured thoracic vertebrae actually took place almost 30 days after the injury. So he came quite late to us, maybe because of the fixation, which couldn't be done because of certain other complications. So he came to us 40 days later, central cord syndrome, and his occupation was he was a construction. He was into the construction business. He was a owner of a construction business. Socially, he was married, had a wife, and he lived in a villa. Social support was good. Yeah. Environment, lives in a flat, has a driver for driving him around. So again, the goal that he wanted, 40-year-old guy, first time being injured, hospitalized, his goal was to walk independently and return to work because he was the owner of a business. So his basic thing was to get back to the business as soon as possible and be able to do that independently. Again, we had to taper it down because central cord syndrome, we don't know how much of upper limb we'll get. There's a lot of deficits in the lower limb. So we told him, let's taper this down goal and let's kind of reach to a consensus where the goal is able to walk with minimal assistance or supervision at the end of 6 weeks, able to climb 5 steps, one person, minimal support, and enter and exit the car without assistance. This was our goal, if possible, at 6 or 8 weeks. Examination, conscious oriented alert, high mental function, normal, sensation impaired for light touch, but proprioception is intact. Impaired for light touch. This is something which is troublesome because it affects our balance. Tone, bilateral upper limbs, lower limbs increased. Power, right side weaker than the left. So he actually had weakness on both the sides, both upper limbs, lower limbs, but his right was weaker than the left. And the worst part was the distal was very weak. So gripping for him was not possible. So this is a major hindrance when we want to provide him with an assistive device if he starts walking. Then his static balance, sitting balance was fair. His standing balance obviously was poor. Yeah, and transfer was total assist at the point of admission. FAC was 0, BBS was 3, Whiskey was 0 by 20. Cannot participate in assisted walking within parallel bar also. So we started the rehab week 1. Bed exercises, focus on lower limb strengthening. Yeah, he comes, we focus on lower limb strengthening. Focus on sitting balance, because without that, like I said, the foundation is sitting balance, and after that, we can probably progress to things other ways. Worked on standing tolerance using the standing frame. We took him to the standing frame directly. Young guy, low limb, having power, everything, we pushed him, and we were able to get him to the standing frame very quickly. So we started by 5 minutes and then progressed to 20 minutes. Sit to stand with 2% assist. Why? Because his lower limb has power. Worked on transfer training using the transfer board. Motomed was initiated in the first week itself because his lower limb has power. So let's push him. Rehab week 2, sitting balance workout. Sit to stand with 2% assist as before. Standing tolerance using the Canadian frame. So we shifted from the standing frame to the Canadian frame because he was able to manage with the power that he has in the lower limb and by hooking his hands onto the frame to stand. So we said, let's push him from the standing frame, which is totally passive, to something where there's active happening. Assessment at the end of the first week, nothing much has changed because, well, he still requires a lot of assistance. Power hasn't changed much. Distally is still weak, approximately same. 2 right is weaker than the left. Sitting balance bus has become pretty much good in static, and dynamic is still poor. Standing balance obviously is poor because we're still doing 1 to 2% assist standing and with the Canadian frame. So balance hasn't changed much. Asmita, you can go down. Yeah. Transfer has become maximal, from total to maximal. So FAC is still 0 and BBS must become 4. So basically, you can just do static sitting. Now we wanted him to go to robotics. Okay, so we continue with bed exercises, but we wanted him to progress to robotics. But the problem with robotics was that he had a suprapubic catheter and he had lots of pain in his thoracic region as well as the right upper rib region. So together, the physician and the therapist together decided that by harnessing him or hooking up either onto the robotic system or body overground system would not be safely done or patient would not be comfortable doing. So we had no other option but to start attempting gait training with maximal assistance using the Canadian frame. Because his low limb has power, his low limb has the ability to do stepping, but because of his weakness and imbalance, you cannot achieve it on, because of his fracture and his suprapubic catheter, we cannot use the Locomat for him. So we changed to Canadian frame and we pushed him to the Motomed to do alternately with the hand and the leg, because it is only the leg that we're using the first 2 weeks. Then the 4th week, the sit to stand was changed from 1% maximal to 1% minimal. So sit to stand is very good activity, works out the whole lower limbs. And standing balance training, contact guard without Canadian frame was initiated. Rehab week 4, we continued with rehab matrix for standing balance. So rehab matrix was now initiated because he's able to stand contact guard. So we said, okay, let's take him 1 step higher. We pushed him to use the screen and do some balance exercises with feedback. And gait training with 1% maximal assist using the Canadian frame. We increased the distance from a few steps to 25 to 30 meters, 2 reps, and reduced assistance for transfer. At the end of 4 weeks, when we assess him, now he has become FAC 1. His power in the upper limb and the lower limb has improved marginally. His ability to transfer has become moderate to minimal. And it is not squat transfer, but stand pivot transfer. So FAC has improved, BPS has improved, transfers have improved. Coming to week 5 and week 6, we moved functional strengthening from bed exercises to functional strengthening exercises like squatting, stepping. The rehab matrix continued for balance exercises, sit to stand training without assistance, close supervision, transfer training, close supervision, gait training with the Canadian frame now had increased to 50 meters. Gait training with the rollator was initiated because now he was showing some grip in the hands, which we wanted to utilize as much as we can. But now the assistance became moderate, and we slowly initiated gait training. At the end of 6 weeks, actually, we would have pushed for another 2 weeks, but patient could not handle any more hospital stay. This is patient preference. This is where his mind says that I cannot handle this, because he had already been in hospital for 80 days, which is close to 3 months, away from his kid and his friends and everything. So at the end of 6 weeks, he said that I need to stop. I need to go. You can probably get me into daycare or into outpatient rehab, but I need to move. At the end of 6 weeks, what we achieved was FACT2, which is minimally assisted walking using Canadian work balance score of 21, which is just borderline high fall risk, medium fall risk, and whiskey of 8/20. The rollator was being used, but with difficulty. The Canadian was much more safer. So we had to leave this patient at this particular point, and this is what we were all talking about. The patient's mood, the patient's preference, and this is why, in conclusion, we have to say that a tailored exercise program is useful to treat a patient in a holistic manner, not only looking at his medical issues, but non-medical issues as well. More RCTs assessing the effect of TEP are needed to understand and refine this process, because you saw that in PD SAFE and in Parkinson's and in multiple sclerosis, this was not effective as much as we wanted it to be. TEP protocols and algorithm formulations can be the future of rehabilitation, and TEPs are definitely the way forward. Thank you so much. We can have questions and things if it's required, if it's needed. Yeah.
Raju, you can take the questions. There are some questions in the question answer. Abhishek, you can moderate if Raju is.
Yeah. Dr. Effie, there's a question for you. What is the transcutaneous vagus nerve stimulation? How does it work for patient with hemiplegia?
Okay, so I think there's two types of vagal nerve stimulation. So there's implanted vagal nerve stimulation as well as transcutaneous vagal nerve stimulation, and actually the more robust evidence is actually for the implanted vagus nerve stimulation to improve upper limb motor recovery. So what the patient actually does is to time the stimulation together with the arm movements. So and they are able to, after a period of training, they're able to do it at home. So transcutaneous vagal nerve stimulation is another technique, as there's auricular as well as cervical. Yeah, so this one is a new addition in the 2023 guidelines, UK guidelines. So I think the evidence for it improving upper limb motor recovery is actually limited at this point in time. Preclinical evidence is actually quite promising, but we need larger studies to look at its efficacy. But because it is relatively safe, and I guess based on the risk profile, they have recommended that it can be used. So for the UK guidelines, they're a little bit more permissive in this sense. Yeah.
Thank you. Another question for you, that how can we balance the guidelines and the limitation of rehab facilities in low-income settings to help our patients? Guidelines say are based in a high-income country model. In LMIC countries, we have real-life problems with not so advanced rehabilitation facilities. How can we balance these HIC guidelines to LMIC context?
So I think the best interventions I've seen have been come from India and some of these purportedly low-income countries, because in a lot of these countries the therapy is relatively affordable. So one-to-one therapy with the therapist is possible, whereas it's really expensive in more developed countries. So actually what's important is actually functional functional training and the intensity of training. So it has been shown repeatedly multiple times that the robot is not superior to the human. So if the human is able to deliver the same intensity of therapy at the same consistency, then actually the human does better than the robot. So technology is not limiting in that sense. And in any case, cardiorespiratory training, strength training, exercise prescription should be given to all stroke patients. Yeah.
Thank you, Nancy. Jason, there's a question for you from Selva. That do you have any recommendations from your end to provide people to improve their participation? How can we improve community ambulation in low resource settings at a district level hospital in India, basically?
Yeah, participation will only improve if we are able to listen to what this patient wants to achieve. And this is the most important thing, because he probably is coming from a rural area, maybe, and he has a farm, and and his goals are very different from what probably a person in the city would have, a person who's working in office would have. Understanding his goal is one very key area to improve participation, because the goals match, his participation will improve. Second, to understand his preference also will matter. Like I said, a patient who's athletic, who's probably done the treadmill, would love to go on the treadmill as compared to a patient who's never gone on the treadmill, and you are like hooking him up and pushing him onto a treadmill. Or like I said, the police officer, he's a guy who's always been in command, and I hook him up to the locomat, and he says that, oh, I cannot do this, because he's always been in command. So understanding the patient's preference, understanding his goal will be one of the most important things that will matter while improving his participation. Second thing is how to improve community ambulation. I think one of the way is probably to go out into the field once a week, once a month, or twice a month. This is what has been done in the other nations where these studies were conducted. They said, let's have 1 or 2 sessions a month of tailored, or we meet the patient, we check on him, and then we say, okay, do this. You continue with this, and then do a review probably after a month. This is probably what's going to happen. Or use of technology. Let's get some video rehabilitation system on. Probably just a mobile device is enough now, and everybody has a mobile device now. Even in India, every single corner of India is connected by the mobile. So just doing a video conferencing or a video rehabilitation is good enough to achieve some of the goals.
Good. Another question first to Jason, then to Effie, is the same question from Dr. Vissanu from Thailand. Does patients are not able to come to the hospital or rehab hospital for therapy because of the transportation issues or difficulty in accessibility rehab? So what is the current status in Qatar and then in Singapore?
Okay, so basically in Qatar, there are residents, and then there are citizens. So the accessibility issues of the citizens are taken care of by the government. The healthcare system over here is more government based, where the government handles and takes care of the healthcare of the people in the country. But the residents have to handle their own transportation. And this becomes a major roadblock, especially when you have the lower income people who actually stay away from the centers, because we don't have a lot of centers outside the major city in Doha. When we go to the outskirts, there are very less and very few centers. So they all have to come back all the way to Doha, and they live actually 30, 40 kilometers away, and they don't have transportation. So transportation actually is a roadblock, even in a country like Qatar, which is said to be very rich. But for the citizens, there's no roadblocks. There's an ambulance which goes, picks them up, and brings them. So it's that.
What about Singapore, Dr. Effie?
So Singapore, we are so small as an island. We are 42 kilometers across only, right? So, but there's still accessibility issues, and it's I think it's more related to social as well as personal factors. So if we wanted to, so there's the government subsidized sort of transportation to rehabilitation centers, although there's a little bit of a queue getting onto that. And then also, sometimes balls get dropped along the way. People don't pick up phones for whatever reason. There's a lot of these logistic issues and then sometimes it's just personnel choice where patients do not want to come or their family members think that it's too difficult. Yeah, that sort of thing. So yeah, same situation. I think citizens and permanent residents are relatively well cared for. Those who are migrant workers or those who are not residents, then that is a little bit of a problem here.
One last question by Greca Fatima for Jason. What intervention do you suggest to patients who are 5 years post-stroke and who's coming to community-based rehab, doesn't have the high-end equipments, as you had mentioned in your presentation?
I would probably just continue with what Dr. Effie just told 5 minutes ago, is that equipment is not the sole reason for improvement to happen. Like she said, robots cannot just displace human. Functional rehabilitation or functional tasks will be equivalent to what you can probably do here in the rehab setting. And the intensity of the exercise matters, like she said. So if ambulation is to be done on treadmill over here, we can always tell him to ambulate over ground wherever he is, or do a functional task of doing a sit to stand or doing simple balance exercises. You do not need a Bertec balance master to improve balance. These are equipments which have probably come in the last 10, 15, 20 odd years, but rehab has always been there since ages. So I think functional tasks, the intensity of the task are two things which will probably decide on how you can manage to do your exercise in the community, and that'll really help the way forward.
Thank you. I think today we had a brilliant discussion on very important concept of motor rehab, and Dr. Epi nicely summarized the best and guidelines of how can we use technology and non-technical interventions to improve motor function in your rehab. As Jason was very elucidated in explaining how the tailor-made exercise programs are definitely helpful for such patients to improve their functional level of activity. And you are both are right. This is a myth that technology is the only way to go forward. No. 90% of work is still done by humans, by therapists. 10% add-on can happen with technology only in selected group of patients. So primarily still it's robots can't replace therapists. It will never happen in future also, especially in rehab. You need long-term, persistent, patient-centric, tailored exercise program to improve their outcomes. And this is very well today said by both the speakers, and I think that's the way forward for rehab in this part of the world. Dr. Surya, please.
So thank you very much for being part of our webinars. Special thanks to the Professor Effie from Singapore, who has presented a brilliant and a wonderful overview on what today is, and Jose has given us about how practical work has to be done at the ground level. So you have evidence and you have groundwork, and so that's how the multidisciplinary team need to work. And AOSNR is providing a platform for all of you to kindly take active participation. Every month, we are just keeping once in a month. We don't want to bombard you with many more webinars. And we look forward to the next webinar on 3rd of October, 3 p.m. India time, occupational therapy for neurological disorder. And we'll send you the link. If you are already registered once, you will get the automatic email, but you can share it with your friends, your colleagues from any part of the world. Most are welcome, and we will be able to provide you a platform where you can learn better things and collaborate with each other. I have Secretary General Vitsanu here. I would like him to say a few words before we depart. Yeah.
Hello. Yeah. Yeah. All right.
Thank you. Say a few words because you have come today after a long time.
Yeah. Thank you very much for the inviting me to join. In fact, it's my duty to join every time as a Secretary General. But unfortunately, today I was a bit late because just have a continuing work in the afternoon. Yeah. But anyway, I'm in. I'm in. And also, okay, next month I'll join you again. And I think so for today's topics, in terms of review of stroke, intervention for weakness, upper limb and gait is very beautiful, and also for the tailor exercise program for neurological disease is also excellent. All right, I enjoy a lot. Thank you very much.
Thank
I'm
you. Thank you.
extremely thankful to all the presidium, because today we had the highest number of presidium. Joy is here, you are there, the Ferry Khan was here. So, it is wonderful to have you all here. And I think this kind of enthusiasm from whole presidium is definitely going to have more number of people from each countries, and we are committed to provide the training and teaching to the whole world, and we will do that. Romesha and Raju, you have been excellent. Thank you very much for chairing the session. And I'll request all of you, if you have any suggestions for the, upcoming webinars, you want to have something and some special speakers you think that should be included from Asia or from out of the Asia, you are most welcome to suggest to me and Abhishek, and we will definitely have them included in the upcoming webinars. So with that note,
Joy has joined.
yeah, Joy has been always there. Thank you, Joy. Thank you. You want to say a few words to all the members? Even Batup is here. So thank you very much.
Okay, bye-bye. Bye, everybody.
So have
Okay.
a nice day and good evening, good night, wherever you are, and see you on 3rd of October. Bye-bye.
Bye-bye.
Bye.
Bye-bye.